From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
Hello and welcome to our listeners around the world. This is the JAMA Clinical Reviews podcast, and I'm Dr. Margaret Wheeler, an associate editor at JAMA. I'm joined today by Michael Auerbach, a clinical professor at Georgetown University who practices at the Center of Blood and Cancer Disorders in Baltimore. Dr. Auerbach joins us today to discuss his recently published review on iron deficiency. Welcome, Michael, and thank you so much for joining us today.
Well, thank you for inviting me.
It's a pleasure. So I wanted just to start off at the very beginning with the title. Why did you and your co-authors choose to write about iron deficiency overall and not just iron deficiency anemia?
Iron deficiency is probably 3 times as frequent as iron deficiency anemia, and it's associated with symptoms and with significantly poorer outcomes across a variety of disease states.
Oh, so that's interesting. You're saying really that iron deficiency, apart from iron deficiency anemia, is very common. How common is it?
The estimates are that there are 1.6 billion people in the world with iron deficiency anemia, and probably another 2 to 3 billion with iron deficiency without anemia.
So you're saying iron is pretty important to human health. Why is that? What role does iron play?
We could spend the rest of the day answering that question, but in pregnancy, it is definitely necessary for fetal development, especially neurologic development.
How do people get iron deficiency and who's at greatest risk?
Well, by far, menstruating individuals and pregnant individuals are at greatest risk because there's an obligate loss of iron in any source of bleeding. Other sources of bleeding certainly put people at risk, people who can't absorb, people who have bleeding disorders, people who have bowel disorders that are associated with both poor absorption and bleeding. But the most common cause is heavy or abnormal uterine bleeding. Up to 40 milliliters a month, 1.3 ounces, you can get all the iron you need from a normal diet. 2 ounces, you can supplement with an iron supplement and keep up with the losses. But beyond that, you can't. One of the reasons is that iron is poorly absorbed. In general, only about 10% of intake is absorbed, and it blocks its own absorption. So when you take an iron pill, it actually inhibits further iron from being absorbed for the next 48 hours. The notion that you can get more iron by taking more pills has now been proven to be wrong, because if you measure absorption of iron, 1 pill a day, 2 pills a day, or 3 pills a day, you get the same. So you're adding toxicity without benefit. So there's your highest risk. A growing baby takes half the mother's iron. And when that iron gets low, the baby doesn't get enough iron. It requires an aggressive replenishment of iron. If you have patients with inflammatory bowel disease, another very high-risk group, they can't absorb, they lose iron. People who have had weight loss surgery can't absorb iron. Virtually any source of regular blood loss is going to lead to iron deficiency, not counting the less common problems of, certainly in the United States, of nutritional iron deficiency, where enough iron is not taken in food, or malabsorption, such as celiac disease or autoimmune gastritis, where there's just simply inability to get iron into the bloodstream from the gut.
One of the things that I thought was very interesting is that obesity itself can cause iron deficiency. Can you tell us a little bit about that?
Sure. Obesity, especially obesity associated with BMIs above 30, are an inflammatory state. So now we have to get a little bit into the science, but obesity raises hepcidin levels. Hepcidin is our regulatory protein, and it goes up when you don't need iron blocking absorption, and it goes down when you do, facilitating absorption. And it would be the most incredible substance in our body if it didn't have the unfortunate characteristic of also being an acute phase reactant, going up in any inflammatory state, making iron less available both by absorption and utilization. So obese patients, besides their decreased utilization because of the distribution of fat, also have high hepcidin levels, blocking their own absorption and utilization.
So earlier, you spoke a little bit about the signs and symptoms of iron deficiency. Tell us a little bit more about those.
Okay, so there are a bunch, but by far, the most frequent symptom is fatigue. And that's a problematic symptom because fatigue is ubiquitous. We all have fatigue. We have fatigue when we work. And virtually every disorder is associated with fatigue. So it's too nonspecific. And although the doctor should ask about it, I don't think you can hang your hat on it. Brain fog, difficulty concentrating, is another relatively disturbing symptom of iron deficiency. But 50% of patients with iron deficiency either have pagophagia, or a pathological craving for ice, or less commonly other substances, or restless leg syndrome, a disorder where you cannot keep your legs still in bed at night and have to get up and walk around because of the uncomfortable sensations. When it gets much more severe and the anemia becomes dangerous, now you start to get hemodynamic symptoms like shortness of breath at rest or severe dyspnea on exertion, and in its most extreme forms, cardiac ischemia or decreased blood flow to the brain. But it should never, ever get that severe because we should take care of it before it gets anywhere close to that.
And so you were talking a little bit about pregnancy before, and one of the things that I loved learning about in reading your article was that iron is part of myoglobin, so it's important to muscles, it's important in lots of enzymes and in neurotransmitters, not just in the blood, even though we usually think of it as being in the blood. Tell me, why is iron deficiency so important in pregnancy and also in outcomes of labor? Can you tell us a little bit more about that?
For reasons that have yet to be completely clarified, iron deficiency is associated with increased peripartum hemorrhage, increased preterm labor on the baby side, small for gestational age babies. And if you do large population studies, sadly, it's actually associated with a small but measurable increase in mortality. But if you believe the World Health Organization statistic, years lived with disability, which is both economic and medical, it's in the top 5 in every country on the planet. It's number 1 in lower and middle income countries, and there are 35 countries in which it's number 1.
We've established it's really important to everyone and very common. So how do we diagnose it?
Take a look at a serum ferritin, the easiest test to order, because if it's low, there's no other cause other than iron deficiency. It's such an inexpensive test and it has such a high yield. The lower limit of ferritin should be 30, and that's based on a variety of physiologic events. First of all, if you do a bone marrow on somebody with a ferritin of 30, there's a 98% specificity and a 92% sensitivity that there's absent marrow iron. So that's iron deficiency. Next, if you take a look at iron absorption or hepcidin levels or reticulocytosis, the inflection point actually occurs higher than 30. So 30 should be the standard lower limit, but in anybody with symptoms, consider 50. If you say the lower limit of normal of ferritin is 15, 15 is already severe iron deficiency. There's actually a belief that the normal hemoglobin for a woman is 12, and the normal hemoglobin for a man is 14. And if you take a look at these inflection points that I talked about just a minute ago, they coalesce around a hemoglobin around 13.6 for women, which I think would be a much more reasonable lower limit of normal.
So now you're bringing up anemia. Should everybody with anemia be tested for iron deficiency?
Absolutely, positively. Because even if there are other causes of anemia, you certainly want to have your baseline iron parameters and watch what happens over time. But it is by far the most frequent etiology, orders of magnitude higher than any other cause.
So you've brought up that there's a lot of variety around the ferritin level that is considered diagnostic for iron deficiency. And in general, you would say that the ferritin 30 or less is diagnostic of iron deficiency. Have I got that right?
Yes.
And in some folks, especially in pregnancy or inflammation or chronic illnesses, you might push that level higher.
You can, but now we have a problem because the actual data on ferritin levels in different disorders is way too variable. So you have to do other tests. And the most easily obtained test is the percent transferrin saturation that is ubiquitously available throughout the country. It has one negative feature, and that it needs to be done after a 5 to 9 hour iron-containing substance fast, because the percent saturation is calculated by the serum iron divided by the transferrin or total iron binding capacity. So if you eat food with iron in it, or you take, for instance, a prenatal vitamin with iron in it before the blood is drawn, you may actually get a prenatal vitamin level or a bacon level or a hamburger level, which will speciously elevate the serum iron and in turn speciously elevate the percent transferrin saturation. Now, there are other tests that are not food or substance intake available, but they're less widely available, such as the soluble transferrin receptor, which parallels the TSAT, or the reticulocyte hemoglobin content. If these were simple to get and routinely available, I think that would be a nice addition to the diagnostic armamentarium. But if you get on a fasting sample a serum ferritin and a percent transferrin saturation, you're going to identify the overwhelming majority of people with iron deficiency.
And tell us, what TSAT level would you say is diagnostic?
19 or less.
Once you've made the diagnosis of iron deficiency or iron deficiency anemia, then what?
Okay, then I think that treatment is necessary. So if you're dealing with mild iron deficiency without active bleeding, an iron tablet taken once every other day so that it doesn't block its own absorption, or once a day if tolerated as well, because they're equal in efficacy, daily or every other day, taken on an empty stomach with a glass of orange juice in the morning. The problem is 75% report intolerance, either constipation, metallic taste, gastric irritation. If that's the case, you should immediately go to intravenous iron and not try to get oral iron to be tolerated, because intravenous iron in one 30 to 60 minute infusion completely corrects most iron deficiency that's not associated with ongoing blood loss. There are diseases in which there's no reason to try oral iron. I don't see anybody with severe heavy uterine bleeding. You can't keep up with the losses. In inflammatory bowel disease, it makes the IBD worse. In pregnancy, it doesn't get to the baby in the second and third trimester. And after bariatric surgery, it's not absorbed. Remember, these people go through a rerouting of their gut to lose weight, and it is essential that they are iron sufficient to maintain the rigors of ongoing weight loss.
So you spoke a little bit about treatment. How about figuring out where the losses are coming from? In menstruating women and in pregnant women, it's fairly obvious. How about in others?
I think it's essential that you chase it. And the overwhelmingly likely source is from the gut. And I think if you have unexplained iron deficiency, that it is incumbent to take a look, certainly a colonoscopy to look for sources of bleeding, and if unidentified, an upper endoscopy. Or if a patient presents with melena, you would go right to upper endoscopy because it's much more likely than coming from below.
So we have identified iron deficiency anemia. We need to figure out where the blood loss is coming from or why the person can't absorb iron. And then we're treating either with iron or IV iron. Is there anybody you would not treat with IV iron or any big complications or adverse effects that come from IV iron treatment?
There are minor infusion reactions that are associated with pressure in the chest or flushing in the face that are harmless and they go away without treatment. Severe hypersensitivity occurs, but it's vanishingly rare, somewhere around 1.25 million doses. I think anybody who has had multiple adverse events with different infusions, an extremely rare individual, I would be very cautious about using IV iron. But otherwise, there's almost nobody in whom intravenous iron is contraindicated. The overwhelming majority of people will tolerate it beautifully.
And what about someone who has become so anemic you give them a transfusion? Have you given them enough iron with that transfusion to be done?
No, you've basically given them none because the iron in blood is not really available for erythropoiesis, and they will need supplemental iron after the transfusion.
Okay, great. This episode was produced by Shelley Steffens at the JAMA Network. You can find a link to the manuscript in this episode's show notes. To follow this and other JAMA Network podcasts, please visit us at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.